Hi, everybody. So thank you for joining us in person. I know it's a different thing to come back to in person a little bit. So we got a smaller crowd in person, but we have a very large online audience today. For those of you online, you cannot see me at the moment because I'm off camera. So I am Matthew Hart. I'm the CEO for Longwoods Publishing. We're the producers of these breakfast events, among other events that we do on a regular basis. So everybody here knows that HHR is a huge issue and will continue to be an issue. And we're here to address some of that today. Supporting and taking us through today will be Carly Weeks, who's a health. Most of you, I think, will be familiar with Carly. She is a health reporter for the Globe and Mail. And then I think year 2 now, Tim. So Tim Guest, CEO for Canadian Nurses Association, just approaching year 2 and just past year 1, right? All right. So, and then Leigh Chapman, who you all know from Health Canada, our CNO. And that's it for me. Carly, it's all yours.
I'm going to borrow Leigh's mic for the moment while we figure this out. So if you couldn't hear me, we're going to take lots of questions at the end, with noting that we actually do have a hard ending at 10 a.m. So we'll get everyone on their way. So before we get to a lot of like the real heart of the issue, I wanted Leigh, followed by Tim, just to set us up for how we got here, because this is not like, I recall well before the pandemic, hearing from leaders in nursing, people working in healthcare, that we have this, this looming crisis. We're here, so how did we get here? What really is the context that, got us to the situation we're in today? Leigh.
Okay, well, that's a great question, Carly, and a good place to start. I think it's very clear that we are where we are currently because of really historic undervaluing of nursing and the work that nurses do. If we think in terms of a more contemporary trajectory, we spent a lot of time over 20 years ago, around 20 years ago, in most jurisdictions in Canada, changing the entry requirements for nurses. So practical nursing came up to a community college level. Registered nurses came up to a baccalaureate level, and nurse practitioners up to the master's level. Yet we still have a very task-focused the way that we have structured nursing work in many contexts is very task focused, sort of harkening back to skills checklists from the 80s that we've certainly gotten rid of. So we spent a lot of time educating nurses, and then we have nurses working in environments where they're very constrained and are not able to be optimized and do the work that they are actually competent to do. And so I think, if we think of just the last 3 years of the COVID-19 pandemic, nurses have been redeployed. There's been, forced redeployment. There's been, inability to take vacation and to have dedicated time off. And it really has eroded the nursing profession. So it's really kind of exacerbated this notion of devaluing the work, the vital work that nurses do. And I think it's contributed to what is now great pathology in the profession. Like, it is more than burnout. It is moral distress, and it is actually making nurses sick. The notion of, psychological wellness is really challenging when nurses are struggling so much in the work environment.
Thank you for that. Tim, do you agree with that? And what would you add to that?
I would agree with it, but I think maybe I'll add a couple of things that are maybe some examples and some specifics. So what we've seen over the last 20 years is a progressive increase in workload and changes in expectations of what nurses do. We have seen expansion of the practice of nursing, particularly if we think about hospital care. 30 years ago, nurses didn't do IVs. Now they're doing all of that. Nursing is always the catch-all when something doesn't fit easily with someone else. So you see that in hospital sectors when largely the rehab team works Monday to Friday from 8 to 4. So nursing takes over after that. So that always goes on top of the work that they're already doing. And I think the other thing that we've seen is that no disrespect, but we've seen progressive funding issues with governments where there's these cyclical cuts that have eroded the capacity of the nursing workforce over the years. Nurses have been saying for 20 years there's a problem. And the pandemic, really, all it did was pull a Band-Aid off of what we already knew. It worsened the situation, but it didn't really cause it. The other thing that I would say is we've also seen a progressive change in societal acceptance of behavior. And there has been a growing increase in violence and behavioral issues that happen in healthcare settings that I believe they happened in the past, but they weren't as frequent. I think there's this growing acceptance that it's okay. And so nurses are much more exposed to violence and potential harms. There's more nurses that are injured because of those instances now than first responders. And so I think the environment that nurses are working is fundamentally different, and I would say not for the better.
Thank you so much for that. And it is obviously, you know, it's distressing to hear about all of these different issues. And you know, I speak to so many different people in healthcare all the time. And certainly this has been, I've been doing health reporting for like 16 years. And I think that to your point, this has been talked about since then. Like, this is not a new problem, but certainly I know a problem that is years in the making is also a complex one to solve. So given all of these layers of challenges, how does that complicate our response now? How, you know, we'll get to sort of some of the solution, but I'm just wondering, you know, given the many different challenges that we are facing, what does that then mean for how we respond to this and the challenge, how, like, it seems like it makes it that much more difficult to respond. What would you say to that, Leigh?
I mean, I would totally agree. I think in many ways we've normalized some of these things. We've accepted these things as normal. You know, it's, for example, nurses work shifts. It's impossible to get daycare for shift workers. It's impossible to find places to rest. It's impossible for nurses to get adequate, you know, nutrition and breaks where they can feel restored. In other industries and other professions, I think we have really, you know, shifted the sort of shifted the balance on work-life balance or how we manage those things. But in the health professions, we've just normalized that it's a 24/7 operation and that we are kind of the sacrificial lambs in the system. Nurses are those gap fillers. And so that requires a massive culture change and a real shift in how we're valuing the essential work of nurses.
What would you say to that, Tim?
I would agree. You know, I'll give a couple of specific things that I would add. I think it will take courage. I think part of the reason that we haven't made the change is you know, some of the challenges cascade on top of each other. And just one specific one, getting rid of mandatory overtime, as an example, would make a huge impact on satisfaction of the nursing workforce. But it's a lever that employers, I think, are afraid to let go because without that lever, you worry about what you would do. There have been jurisdictions that have eliminated mandatory overtime in the collective agreement. Nova Scotia is one of them. It's still functioning just like the rest. The world didn't end. And so I think it just takes one that will be willing to make some of those changes and to move forward. I think one of the other one is, you know, we come from a culture that was hierarchical. It was very colonial impacted, rules based, and sometimes it's hard to give things up. Nurses tell us they want more control over their scheduling. One of the things that is hugely dissatisfying for them, but it's really hard to give up control of that and share that control. You know, one of the things that we hear that nurses also want is they want to have more input and more say. And when you see some of those things, it makes a difference with your retention rates. It makes a difference with recruitment, you know, success. And I think it just takes courage. It takes a leap of faith. I think it takes a culture that brings the nurses to the table to have input and to share the decision and the accountability for putting the decision into action. You know, I think that's what's needed.
I want to go with that thread for a second, because I think one of the issues we've seen for a long time is that, the voice of nursing maybe isn't heard as much as it needs to. I mean, the fact that we didn't have a chief nursing officer for, a decade or so. And I think often even in the media, we don't hear enough from nurses. And in some cases, that's because nurses aren't quite as empowered to speak publicly. And there's more of like a fear of basically fear of losing their jobs, whereas physicians don't have that same kind of constraint. So I think that that's part of the challenge. I wanted just to go with that comment just on sort of how we need to hear from nurses more. And if you're each to sort of, and you're both in positions of leadership, but, wondering what sort of the message needs to be for people who are making policy, people who are looking at, what do we need to do about recruitment and then retention? Like, what are some of the messages just about including voices of nursing? What mistakes have we been making? What do we need to do to make sure, there's actual that representation to make sure that the voice of nursing is part of those decisions and changes that are being made? Leigh, perhaps I'll put that to you first as someone who's, kind of in charge of nursing in Canada.
If only. I think that there's part of the challenges that we hear a lot of negative stories of nurses in the media. And the difference really is nurses are generally employees and physicians are generally self-employed contractors. So that's a key difference. And I think because nurses are employees in most circumstances, they are kind of treated as cogs in the wheel and replaceable, or they can be redeployed to other areas, or if we're short, if we can bring in agency or travel nurses to sort of plug the holes in the system. But I think we need to hear from nurses, and we need to really amplify the voices of nurses, and that's certainly a key part of my mandate in understanding nursing from a pan-Canadian perspective, from coast to coast to coast, and really bringing those stories to bear in nursing policy and health policy, but there's lots of opportunities at the local level, at all levels, at the employer level and so on, to really amplify the voices of nurses. One example, perhaps in a healthcare facility, in a hospital or any other healthcare facility, is to involve nurses in practice council and governance and decision making, and really having a container, an opportunity for nurses to be part of decision making within the organization. I think that when we allow for those opportunities, the potential of nurses is really unleashed. And I think there's those examples. When I mentioned the media, it's a lot of doom and gloom. There's a lot in the media around nurses working in agencies at inflated rates of pay and so on, and how much this is costing the system. But who can blame nurses? And I think that is the perennial problem, is we blame individuals for system issues. And the system issues are the issues within the system, the healthcare system, that need to be remedied. But I mean, there's miracles that happen every day in healthcare, often at the hands of nurses. We don't hear those stories very often.
It's very true. Yeah. And I do take some of the blame for the doom and gloom. So I'm sorry about that. Tim, what would you say about that? Because you started talking about sort of the, amplifying the voice, like getting the voice of nursing out there. What sort of do you mean by that? What are and maybe some examples just from your your experience, your professional working experience, about the importance of that?
So we spent a lot of time advocating for the return of the chief nursing officer at Health Canada. Some of what we've talked about is needing to have a nursing voice at provincial and territorial government levels as well. There are in many of them, not all. They're not all at the same level of the decision-making matrix. And so, one of the things that we've talked about is that the nursing voice needs to be at a high enough level that they can actually influence government policy decisions. The other thing that we've talked about is that organizations need to have senior level nursing role or voices and roles at the table. In Ontario, as an example, it's required that hospitals have a chief nursing executive appointed. That is not the case in provinces, every province and territory across the country. And so there's variation. We believe that nursing departments should be led by nurses. And there's been lots of conversations we've had with nurses that it matters to them, and it makes a difference with how easy it is for them to transition into practice. As an example, when they're new, when they've got nursing leadership to go to help them with that that transition. There needs to be more opportunities for nurses at all levels to participate in decision making. And there's lots of examples across the country where employers have put in nursing advisory councils that they really encourage nurses to come and participate in decisions and to help them through issues. And I think the ones that are the most successful are the ones that they're really meaningfully engaged. The nurses are paid to go. They're not expected to do it on their own time. You know, that the employer really wants them to participate. And so I think there's lots of good examples of where that's happening. I'll give you another Nova Scotia example, just because I think it's unique, is the government there has created a nursing advisory board that has representation from the union sector, from education, from regulation, from employers across all sectors. They come together, they work through issues in a very effective way, and they advise government on where to spend their nursing. They've got a pot of money that they've put together for supporting the nursing profession in the province, and that group advises government on where it should be spent. I think it's a really good model that could be spread across the country. You know, we hosted the International Council of Nurses Congress in Montreal in last July. And one of the things that several of the other countries told us, as Canadians, they view us as the pilot people of the world. We pilot all kinds of stuff that they're really glad we do because they implement it. But what they told us is we don't. Which they thought was bizarre, that we spend all this money, all this time piloting all these great programs and then do nothing with it.
Tim, you're the master of segues today, because I wanted to ask about, what are some of the challenges in terms of, getting some more of these solutions on board? And I promise we will talk about solutions, but, just that this whole idea that, we kind of know some of the things that we could do and some of the changes we can make. Why aren't we doing them? What are some of the key issues standing in the way? So, Leigh, I'll give Tim a break and ask you to comment on that first.
I mean, often the challenge is money. I would say that, we've seen an historic investment in healthcare this year of over $200 billion. And, really a dedicated commitment from the federal, provincial, and territorial health ministers meeting or health ministers to address nursing retention specifically, as well as some of the other workforce challenges that we're facing. So, I mean, I think a challenge and an opportunity is always money. But as Tim said, I think it requires courage and leadership and really almost a willingness to pilot, try, test, and fail initiatives. But I think I understand the focus on recruitment. It's sort of a natural preoccupation of either healthcare organizations or of provincial and territorial governments, because they don't want to close emergency departments. They want to be able to, they don't want to have protracted wait times. They want to keep services going within their respective healthcare systems. But, it does require this shift from just sort of filling vacancies to actually looking at how we're redesigning the system. And that requires leadership.
We're going to come back to that. That's an excellent point. Talking about other barriers and things like that, what comes to mind, Tim?
I think it's we're in this firefighting, it's like being the rat on a wheel, where all the system is doing is trying to put out fires. And I think it really creates a challenge individuals within the system to be able to focus on some of these other important issues. I worked in the system for most of my career, and all it takes is one call from an MLA and your whole day is switched, right? And so I think we react to issues sometimes that really take us away from the work we should be doing. And so, but I agree with Leigh, it's focus. We need to measure the things that work, and then we need to actually roll them out and expand them and have more people doing them. You know, often we beat each other up. And one of the things that Minister Holland said when he spoke to the physicians at a meeting earlier in the year was that we need to be more transparent in the system, and we need to tell the public when we fail and why, learn from it, and it needs to be okay for something not to work. And then you try something else to fix it. And I think as there's a culture in the system that we're afraid to be that open, which I think has prevented us from solving some of these issues. Because, you know, there's many ministers who've been burnt in effigy when something doesn't work right. And I think we need to change the culture in order to move forward.
I think that's an excellent point. And yeah, certainly it can often be difficult as someone who's trying to get answers from, you know, health organizations and leaders. It can often be difficult to get some of that information. And I think that there's a real tendency toward, you know, being like wanting to not let that information out, or really being defensive about it, afraid of speaking about mistakes and or potentially being called out for something that went wrong. So I think that's a really great point. I wanted to just circle back to something Leigh was mentioning with regard to, you know, recruitment and retention. And, you know, in the past couple of years, you know, we've seen so many different, you know, ministers from around the country and organizations speak about the importance of recruitment. You know, we're going to get more nurses here. We're going to get them working. We're going to get new grads. But at the same time, you know, this whole idea of what kind of system are they walking into, and are they still going to be there in a couple of years when they realize the realities of what's going on in the organization they're working for. So when we look at the idea of, you know, those, you know, recruitment and retention challenges, what would you say, you know, are sort of some of the key issues we need to be thinking about, particularly around, you know, innovative solutions that we can scale up to retain nurses?
I mean, there's lots. That's why, you know, I would say since I've been in the role, now I think about 15 months or so, there's been calls for sort of like a national nursing strategy. Well, the strategy is really in the focus on retention. So, you know, we've convened a advisory group and then held this large retention forum in the summer, I guess in June, and are just in the final stages of developing nursing retention toolkit. So it contains all those, you know, juicy bits of examples of where these wonderful things have been occurring across the country in support of nursing retention. So some of the examples that I like to provide are in Manitoba, for example, there's a provincial float pool. And I think this is really innovative. About 70 out of the 115 nurses that they have within this provincial float pool came from travel nursing or agency. They're now within the public system. And they can work, you know, in downtown Winnipeg, but they can also go work 2 hours outside of Winnipeg, have their accommodation and travel compensated. They work for a set period of time. They find it enriches their practice. It enriches the practice of their colleagues, and then they can go back to their sort of home base, all within the public system. So nurses are able to get that flexibility within the public system. And this is a model that I know other jurisdictions, for example, in the territories and other jurisdictions are trying to emulate. I think the Provincial Leadership Council model that occurs in many jurisdictions is very promising. It provides a forum for some of that decision-making for that involvement. Nurses are very strong advocates, whether it's for their patient at the point of care, for their colleagues, for themselves, or for the health system. And so I think we can harness that energy and harness that advocacy potential. I think I mentioned the example of daycare. There's some 24/7 daycare facilities that are popping up in other jurisdictions, housing for nurses. Like these are basic things that I think we have accepted as normal in other industries or in other professions, but we don't think of them in healthcare. You know, dedicated rest space, free parking. These are not really, it's not that innovative, but I think these are things that we haven't even considered, transit subsidies, things like that, that nurses need. And certainly, to Tim's point around the violence, bullying and harassment, and racism in healthcare, ensuring that there are zero tolerance policies and the consequences as well, when these things occur, so that nurses feel safe in the work environment. Again, basic things, but things that we haven't had in the nursing profession for some time.
And I wonder if, we spoke about undervaluing of nurses and it feels as though, from so many stories I've heard that nurses have just been kind of expected to just carry that load. That's just what they do. And so when, and other health professionals as well, just kind of like, shut up and care for patients. But then as time goes on, we've started to see that there's only so much a person can carry. And that's when you start to see, people still, your hospitals are still largely open, people are still largely getting cared for, but the story of what's actually going on inside, it's clear that the quality of care starts to suffer at a certain point, right? I was speaking to some people working in hospitals this week who are just very worried about, the ability to actually provide the appropriate level of care for people under the strain that they're facing. Tim, I was hoping you could add your perspective to that as well, sort of this, recruitment and retention, both issues that we're facing, but, what I hear is that retention is really where we need to be focusing a lot of our efforts. Before we can think about recruitment, we need to really get retention right. So what does that look like from your perspective?
Yeah, we've been advocating to government for probably 18 or 20 months now, where we've really said that the solution to get ourselves out of the situation we're in needs to be multifocal. We said that it needs to start with retention, that we have to maintain the workforce we have, particularly as the numbers of nurses that have self-identified as wanting to leave the profession, exhibiting symptoms of burnout, deteriorating mental health conditions. The incidence of that across the workforce has just exploded. And so we need to do everything we possibly can to support nurses and keep them, because, I think if we look at it, replacing the gap with increasing domestic supply and international recruitment, it'll take us a decade to fill that gap. And so some of what we've talked about is you need to focus on the work environment. Nurses are telling us the work environment is the predominant thing that's pushing them out. And so it's things like I've already commented about, scheduling mechanisms. It's about dealing with violence and those harms. It's about scheduling and giving nurses more ability to influence their work environment. It's about decreasing the amount of overtime that they're working. Some of what nurses have told us is that they go to work and they don't know if they're going to get to go home. I've heard from nurses that have told me that they worked 24 hours and they nearly got in a head-on collision on the way home because they were too tired to drive, because they didn't have any options of how they could get home. We hear from nurses that they would like to have more supports to be able to advance their education, to give them options. And particularly we hear that from nurses from underrepresented groups that find it very difficult to grow their careers in the health system. And Leigh mentioned the issue about racism. We know that it's a factor. And I think it's all of those things. Mental health supports is another one that nurses have told us that's a fundamental issue for them, that they have inadequate supports to help them through some of the critical issues that they have dealt with and some of the things they've experienced over the last 3 years. And another one is that nurses have to prove the source of injury if they've had a PTSD injury at work. First responders don't. Why is there a difference? Some of those things are some of the things that I think need to be addressed in order to solve this issue.
It's so many basic things, really. For sort of lack of a better word, but so many fundamental things that are just, sort of taken for granted. On the issue of, like racism and, there's so many different aspects to that. But, the federal government has promised that, or basically told provinces and territories they need to do a better job of collecting data to try and figure out, how many nurses are working in a certain area, what what regions are they in, like, basically to identify where the gaps are, right? And part of that is also trying to collect some of that race-based data to try and, get an understanding of who is not being represented and where, and really trying to figure out where some of those challenges are. And I'm just wondering if, maybe each of you can provide a thought on, where or how this data strategy can try to help out from a nursing perspective, what kind of differences that could make. I realize it's probably, some time away from being reality, but what do you guys think that could mean for nursing?
I mean, the data piece is really complex, and that was part of the accountability around the funding transfer this year. Or the funding agreement in principle this year. And I think that, it's the lack of comprehensive health workforce planning data has impeded our ability to do forecasting and that sort of supply and demand projections of, how many nurses do we need? How many are we short? We talk about a nursing shortage within Canada. And, some of the metrics for that are our vacancy rates, but we don't really have a good sense. We have almost 500,000 nurses in Canada. We don't have a good sense of how many nurses we need. And this is in the context of a global nursing shortage. And so the data piece is really critical, and I think it will help. But, when it comes to, the race-based data, we need to know that the diversity of people in Canada is reflected in our nursing workforce or not. And we don't have that data. We certainly know that there is a lot of, systemic racism in healthcare, but I think the data would help us develop interventions and understand where the interventions are. Like, healthcare in Canada is really such a Canadian value that we take so much pride in. And when it's under threat, as it is right now, in terms of the crisis that we're facing, the impact is often, violence and aggression, often, at the point of care at the front line. So nurses are directly impacted. But the data piece is critical for our workforce planning. And I think that's why it has been a major priority of this government.
Tim.
I guess a couple of things that I'd comment. I think that, we saw a shift in federal, provincial, territorial collaboration, I think, over the last year. Back in November, when the health ministers all met in Vancouver, they're all in the room, they're working together, and the premiers scuttled the whole thing with an announcement in the media, unbeknownst to the ministers. It was a really interesting thing to be there to watch. That they were planning a joint press conference to talk about the things that they got. Needless to say, that didn't happen. And then Charlottetown was a complete shift, where I think they came out of it with some collaborative things that they've agreed to work together on. The bilaterals, as an example, just the federal and provincial governments that have been able to negotiate the bilaterals was a huge step forward. The provinces being willing to actually be accountable for those dollars was a total different change in the conversation that we had saw. Now, the interesting thing is BC is the only one that's actually got an agreement yet. The rest of them are still sitting in limbo. So we're anxiously waiting to see what happens with them. The other thing that I would say is that, we applauded the federal government for announcing the money for the Center of Excellence for Health Human Resource Data. But the one thing that we keep talking about that the provinces and territories we've not got any traction on is actively agreeing that there needs to be a pan-Canadian HHR plan. That it's crickets. That's the one piece that we keep asking for, that we're not getting anywhere, that I believe really needs to happen. We know how many nurses there are. We have no idea what they're doing. So that's part of the issue, right? So you can say, yeah, there's 466,000 nurses that are registered or regulated in the country in order to work, but we have no idea how many of them are actually working, what they're actually doing, what percentage of a full-time equivalent they're doing. We don't know any of that.
And obviously that's a huge gap. Talking about this pan-Canadian this idea of a pan-Canadian strategy. I mean, why do you think it hasn't gotten the traction that, it likely should, based on the urgency of the issue?
To be honest, I don't know. I think you got to start somewhere, and for government, I think it's probably been a big step in order for them to make the decision to create the infrastructure to have the data, and so I'm hoping that maybe the Pan-Canadian plan is kind of in the future and is being talked about. I'm not going to put Leigh on the spot to find out if that's the case. But I guess they needed to start somewhere, and they've at least moved, and so it's not all bad. But the reality of it is Australia has a mechanism to be able to do planning. They've kind of left it behind a little bit, and so I think it was effective. So there's good examples in the world where governments are doing I think better HHR planning than we are, that we could learn from. And so I hope that it's something that's on the horizon.
Thank you so much for that. One thing we haven't touched on yet, but I would be eager to get your thoughts, both of you, is basically on the issue of recruitment. We've been hearing, for instance, a lot of attention paid to the importance of recruiting internationally educated nurses, making it easier for those nurses to work here. And tying to that issue, I wanted just to see if you could speak about ethical recruitment and how that looks, because it's great to recruit, and we've obviously we need to focus on retention, but recruitment is sort of part of that. So I guess hopefully we get to a point where the working conditions are better and you're recruiting people into a system that's working. But there's issues around ethical recruitment. So what do we need to be thinking about, and what should sort of policymakers and leaders be considering? Leigh.
Yeah, I mean, it's a really good question. I think the challenge is that a lot of the focus has been on recruiting internationally, and certainly our priority from a federal perspective is on accelerating the pathway towards integration for internationally educated nurses who choose to come and work in Canada. And that's different, very different from direct targeted recruitment that is certainly happening at some of the provincial or territorial level, and with employers directly. But our focus is really on those who are coming here, ensuring that it's not a years-long, expensive process towards licensure and integration, because many of them, the settlement process is so difficult when you're immigrating to a new country. And we need them working in healthcare as soon as possible, in ensuring that they're safe and competent to practice, but really trying to accelerate their integration. So, and certainly our focus from a federal perspective is also ensuring that, we have a Canadian lens to ethical recruitment, that we also have a sufficient domestic supply within Canada, and that we are, we're a rich nation, that we are producing enough nurses to sustain our healthcare system, and not taking from depleting other countries' health human resources.
Certainly, yeah, that's really important. Tim, what would you say to that question?
I think a couple of comments. We did advocate early on we've been advocating for a few years now on the need to improve the process for licensure of internationally educated nurses in the country. It was a very difficult process. It took years for some of them, cost them thousands and thousands of dollars. It's not perfect. There's been huge improvement, I have to say, on the issue of licensure of internationally educated nurses. There needs to be more focus on, like Leigh said, integrating them successfully into the Canadian workforce. We hear from them that it's really challenging for them to adjust to working in the Canadian context without supports. You could imagine if you are the only person that looks like they do thrown into a rural community where there's no one else that has any understanding of their culture, and you want them to thrive. It doesn't make a whole lot of sense. We need to do the same thing for our new graduates, however, domestic graduates, about transitioning them successfully into the workforce. I would say that we very much support nurses from around the world who want to choose to relocate to Canada to immigrate. We do not believe that we should be in the way of that and putting any barriers that prevent anyone from wanting to immigrate to the country there. We do, however, think it is completely unethical for a country like Canada to be going to these countries actively recruiting. They're the top 6 countries recruiting internationally are all OECD countries. Canada is one of them. We are in the top 7 countries that are recruiting internationally in the world right now. We have 11.1 nurses per 1,000 population recruiting from sub-Saharan Africa that has 1. It doesn't make any sense. India's got less than 2 nurses per 1,000 population. We're recruiting from India. Philippines has got less than 5 nurses per 1,000 population, and we're recruiting heavily from the Philippines. You know, we have to really look at what it is that we're doing to the domestic populations of those countries when we're actively recruiting a scarce health resource from them.
I think that, yeah, that's really well said. And I mean, I've seen, I think in recent years, examples of provinces sort of using their international recruitment as sort of like a boasting tactic, like, see how well we're doing? Like, we're going to all these countries and trying to bring nurses here. Anyway, fodder for a good story, perhaps. So we'll connect later on that. On the issue of, you know, new graduates, I'm interested, and I know that you may not sort of have the number of applications at the ready, but I'm just wondering your sense of, and Tim, this might be, like Leigh, I don't know if you would be able to answer this as well, but you know, just from conversations you're having with nurses or people who are working, are there still, like, are people getting scared off of the profession? You know, or is this, you know, I think part of the fear of the focus on how bad things are is that we're going to, people are no longer going to want to get into this as a profession. And I'm wondering if you know, either of you are seeing that manifest itself in reality.
You know, early in the pandemic, when everyone was out banging their pots and pans on their patios, nursing programs across the country were oversubscribed. There was huge wait lists. There was a huge demand from individuals wanting to get into nursing programs. I haven't heard specific statistics, but I can tell you that I was in Edmonton in the fall, and one of the university programs in Edmonton did not fill all their seats. A huge shift. And so there, it has had an impact. And I think that's, some of that is the negativity that's out in the public. I think it was important for the public to hear nurses' stories about what their environment is like. But I think it's time now for us to shift that message, and we need to start talking to the future, and we need to see actual improvements to solve some of those issues and move on, because I actually think it is having an impact on individuals wanting to choose nursing as a profession.
Thank you for sharing that. You know, it's interesting. You know, my sister works as a nurse, and so I'm maybe biased on the subject as well. But you know, she, you know, her group of colleagues are some of the most fantastic people, and it sounds like they have this great fun time at work. So as much as we focus on things that have gone wrong, or you know, nurses, yeah, working at a private agency, how dare they? Nurses who are, you know, being bullied at work, important to shine a light on that. The things that are actually going right in healthcare, you know, we don't speak necessarily enough about. Leigh, I would love your thoughts on that as well. Just sort of this concern perhaps about the future generations.
Yeah, absolutely. So I would say, you know, when I came into the role just over a year ago, I was hearing about 4 to 8 applicants for every nursing education seat in the southern provinces, and a completely inadequate supply in the territories as well as in rural and remote areas. And now I'm starting to, this fall, I've been starting to hear about nursing education programs across the country that haven't been able to fill seats. And there's a lot of political pressure to increase seats without actually considering how we can ensure quality education, whether we have sufficient faculty resources, clinical placements, and so on. And when the service side of healthcare, like the healthcare delivery, is constrained, so too is the learning environment, because that's really the practice environment in which nurses learn. So retention really starts in nursing education programs, and we're seeing attrition also, not just inability to fill seats, but also attrition from nursing education programs. So we really need to ensure, you know, it's very hard in a strained system to have nurses as supernumeraries, as learners, right, in this dedicated time and space for learning. But that's absolutely what we must do. And I think that You know, I firmly believe nursing is a wonderful profession, and I'm so glad to hear your sister is a nurse, Carly. And that's the, you know, the joy in the profession. There's so many things you can do in the nursing profession. I talked about it being, you know, healthcare being kind of a Canadian value that we kind of uphold. So we need to think of nursing as a profession of choice in supporting and sustaining our publicly funded system. But that requires a shift in focus on retention and really valuing the work that nurses do.
Thank you so much for that. And we've talked about so many interesting things. We have 13, 12 minutes left. So I wanted to see if there are questions from the audience here, questions online. If not, I still have plenty more questions, but I thought I'd give everyone here a chance. So if there's any questions in the audience, feel free to raise your hand and I can repeat the question for the audience online. We'll go to online questions as well if there are any. For people who are listening online, the comment essentially, I think, saying that, you know, there's an opportunity to use international nurses coming to Canada on fellowship. So not sort of, you know, poaching, but just really leveraging an opportunity to use the expertise. Yeah, both sides. So I don't know if either you want to comment on that, but that's a helpful idea. So thank you for raising that.
Just a comment. I want to thank you for coming to Canada. But also, you know, I think we spend a lot of time telling learners, whether it's new graduates, students, or internationally educated nurses, what they don't know. And I think you've really shifted our focus. And I think that's a necessary shift to think about what we can gain from learning from our colleagues from around the world, and as well as our new learners and new graduates, because there's so much to be gleaned from your and their expertise.
Thank you for that. I'll see if there's a question online before we go back to the room.
So there are lots of questions online. This is a very vocal group. I've been kind of reading them and trying to group it all together. There is a lot of questions about education, and a lot of concerns about workload and continuing education not really kind of meshing. Do you have any comments on how people who want to get involved in continuing education basically can?
I guess, you know, the first comment I would have is access to resources in order to be able to do continuing education. That's one of the biggest barriers that we hear from nurses is, you know, there's a real lack of access to sufficient grants and bursaries and funding opportunities to help them support going back and continuing their education, particularly when you're looking at a workforce that is 98% female. You know, it impacts completely the home environment that individual is learning from, particularly if they're a single mother that's trying to raise a family on one income. And so I think there needs to be more flexibility for nurses to be able to advance their education, more funding opportunities for them to be able to access, because the reality of it is, as Leigh has said, you know, we're losing faculty in nursing programs, and you need to get those experienced nurses from somewhere. And if you don't support them to advance their education, you know, it's like the chicken and the egg. You know, it's one of the things that nurses have told us is one of their fundamentals in order to keep them in the workforce is better access to professional development.
Just a couple of questions there. So you had your hand up in the back first. For the online audience. The question is essentially, you know, how do people who are working, how do we support the people who are currently working to train people that are coming in, you know, take on students and sort of continue that like a, you know, great tradition in healthcare. Any quick thoughts on that?
Thank you for bringing that up, because that is a specific item that we at the Canadian Nurses Association have been advocating for government to add additional resources to it. And one of the specific things that we've said is that there are nurses at the back end of their careers that don't want to work full time. They want to contribute. They believe they have something to offer students that are coming into the system. That what we have said is, because the workforce is too taxed, they're running short, the workloads are high. If government supported employers to be able to actually have individuals in their workforce, that their focus was doing part-time transitional support, looking after students, working with students, mentoring, that's their sole role. We believe there are nurses that would choose not to retire, that would stay in the workforce and particularly do that. The challenge is that employers don't have the funding in order to create those roles, and that there needs to be an actual commitment to supporting it. We've often said when we've talked to government about the need for the investment in the educational system, it needs to be about increasing seats, increasing things like infrastructure and nursing programs. It's about increasing faculty, ongoing permanent funding, not one-year grants that the faculty have a hard time even recruiting the person to teach in the time frame they've got the money. There needs to be a change in how that happens, but there also needs to be investment in the clinical setting that does exactly that, puts resources in place for individuals that might have left the workforce, stayed, that have huge experiences to contribute. It's a really good example that we believe that would make a difference.
Thank you. Leigh, what would you add to that?
Just a quick comment that I think, as Tim described, these late career initiatives are really, really fruitful, and, they've been implemented at, the Ottawa Hospital is doing something, St. Paul's Hospital in Vancouver, and it's enriching for the late career nurse as well as for the new graduate. Sometimes the late career nurse doesn't have the answers, but there's certainly resources. And I think in COVID, we saw a record number of nurses coming back to practice to help with vaccine efforts and so on. We need their expertise. But I will say as well, we funded federally the Kazan residency program, which is really to support preceptor development. And again, to support that capacity need for, nurses to be preceptors, and perhaps preceptors who haven't precepted before, because preceptor burnout is very real, particularly with the workforce challenges that we're facing.
Thank you so much for that. There's more hands and questions than we have time for, so I'm going to go quickly online. We may be able to get to two, but probably one last question.
Yeah. So again, I'll kind of jump this all into one big question here. There is, although we don't want to talk about it, there is still a lot of talk about salaries and what role salaries play in retention. Budgets tend to be typically used by hospitals, so they're using nursing salaries, which in effect deals with full-time permanent roles for nursing. So what role can salaries play?
Yeah, that's a great one. Who wants to take that on first?
Well, I'm getting the look, so I'm assuming that it's me who's going to. This has actually been one of the things that we surveyed nurses a year ago, and what we were trying to get a sense from them were what were their policy priorities for our advocacy work. And one of the things they told us was equity of pay was a huge issue. Nurses across sectors don't all have equity of income. The long-term care sector for many, many years was way below hospitals. Community was below hospitals. There was gaps between what faculty and nursing programs were making compared to nurses that were working in unionized hospital settings. And it created all kinds of challenges. And we continue to hear that those issues remain. We haven't seen the nursing salary increases across the country that have been probably as equitable as what we've seen in some first responder collective agreements, particularly police. In some municipal jurisdictions, they've had double-digit increases. We've not seen those sorts of increases from a nursing perspective. Quebec, as an example, is behind most of the country in their nursing salaries, and well, we can see in the media what's kind of happening there, and so it's an ongoing situation that I think it's a real issue. It's one that matters to nurses. They've told us that in some of our surveys. I think you'd have to have a conversation with Linda Salas at CFNU to really get a sense of what the issue is. But it's one that nurses are talking about for sure. It's about respect.
Thank you so much for that. And just in the next 30 seconds, Leigh, if you want to add your thoughts.
Yeah, I mean, I would echo Tim's comments that it really is fundamentally about respect. I think the exponential rise in travel and agency nurses, shows that we actually can pay nurses. And if we shift that focus to valuing nurses who are in the public system, I think it would really go a long way. It really is about valuing the vital work that nurses do and respect for the nursing profession. And I think part of that is compensation, but also part of that is optimizing the work environment.
Thank you so much for that. And thank you everyone for attending in person and online for the questions. And of course to Leigh and Tim and to Longwoods for organizing this discussion and being here today. Thank you all.